Good evening, everyone. We will start in 5 minutes. Good evening, everyone. I'm Nancy from the marketing team. On behalf of Elsevier India, I am delighted to welcome you all to this fantastic session on diseases of skin appendages by Dr. Neena Khanna. Please note that you will be on mute by default during the webinar, but if you have any questions for the author, you can put them in the Q&A section. All questions and queries will be addressed by the author at the end of the webinar. Participants joining us on YouTube can add their questions in the comment section. Participants will also get certificates on the completion of the webinar. And don't forget to participate in the quiz after the session. Dr. Neena Khanna is here with us today to teach us about acne and hair disorders, which are common problems among the young generation. She's a professor and head of the Department of Dermatology in Amrita Hospital, Faridabad, and a former Dean Academics, professor and head of the Department of Dermatology and Venereology at AIIMS, New Delhi. Dr. Neena Khanna is an accomplished professional with numerous awards, including a Lifetime Achievement Award by Indian Association of Dermatology, Venereology and Leprology in 2023. She has also been recognized for the Ambadi Oration Best Teacher Award and Professor L.K. Bhutani Award by IADVL. Her contribution to the health education sector is commendable. She has written 175 articles, 30 chapters in books, and 11 books, including the illustrated synopsis of Dermatology and STDs. Now, I would like to invite Neena ma'am to take the floor and enlighten us on the topic. Thank you.
Thank you, Team Elsevier, for having me here and allowing me to do something which I really enjoy, that's interacting with students. Today, I'll be talking on disorders of skin appendages. And what we're going to learn in this lecture is the etiopathogenesis of acne, the risk factors of acne, diagnose and grade common types of acne, describe general and specific treatment for acne. This is in your competency-based medical education curriculum. And I will also talk about the common types of alopecia and common disorders of sweat glands. Now, the first and the foremost is disorders of sebaceous glands, and acne vulgaris is one common disorder of the pilosebaceous complex with a usual onset in adolescence. It's characterized by polymorphous lesions. Now, this is almost a ubiquitous problem, extremely common, and I do not recollect an adolescent who has not had some form of acne in their lifetime. Now, the onset is usually between the ages of 12 and 14, being earlier in females, and about 70% of the patients, the acne usually subsides in the third decade. It affects both sexes equally. However, the severe forms are several times commoner in the males. Now, it's very important to understand the pathogenesis of acne to optimize therapy. One initial event is probably occlusion of the pilosebaceous opening. Concomitantly, there is increased microbial colonization, particularly with Cutibacterium species, especially Cutibacterium acnes. There is increased sebum secretion, and the accumulation of this is that the sebaceous gland ruptures with the spillage of the sebaceous secretions into the dermis, which initiates an inflammatory cascade. There are several factors which modify acne. An important one is genetic predisposition. There are some people who believe that diet is very important. Cosmetics are equally important in triggering acne. Several women who get acne complain of a premenstrual aggravation, and psychological factors also are very important. Now, clinically, the patients with acne have a background greasiness and patulous follicular openings. The lesions are polymorphous, so they are characterized by comedons, which is the pathognomonic lesion. We'll talk about it briefly in the next slide. There are papules, there are nodules, there are pustules, and there are what are called cysts, but are actually nothing but fluctuant nodules. So they're basically pseudocysts. And also, acne is characterized by scars. Now, comedons are the pathognomonic lesion of acne. There are two types of comedons, the open comedon or blackheads, and the closed comedon or the whiteheads. Another characteristic feature of acne are the scars, because acne lesions heal with scarring. The scars can be atrophic, the atrophic scars or depressed scars can be ice pick scars, box scars, or rolling scars, or they could be hypertrophic or keloidal scars. The distribution of acne is very characteristic and is used as a diagnostic clue to making the diagnosis. So characteristically, the face is involved, and in some patients, you can get the shoulders, the upper chest, and the back being involved. If acne occurs at unusual sites, suspect an acneiform eruption either due to drugs or due to occupation. Now, in this particular patient, you have retroauricular comedons, and this is because of his occupation with chlorohydrocarbons. Now, there are several variants of acne, the two common ones being acne conglobata and adult female acne, and we're going to only discuss these two because of paucity of time. Now, acne conglobata is characterized by bridging abscesses. You can actually see the bridging abscesses here. You can get cysts, sinuses, which are filled with pus, and multiparous comedones. They heal with deep pitted or hypertrophic scars, which are again joined by keloidal bridges. It's also associated with other manifestations of follicular occlusion syndrome like hidradenitis suppurativa and dissecting folliculitis. Adult female acne is another common form of acne which occurs in women who are more than 25 years old. And it could be just the prolongation of adolescent acne or could start de novo after the age of 25. It's usually characterized by moderate to severe acne in the lower half of the face, like in this particular patient. It's often treatment resistant, relapses soon after stopping therapy, and it's often associated with features of hyperandrogenism in the form of hirsutism, seborrhea, and female pattern hair loss. It's important in such patients to rule out a polycystic ovary syndrome. Now, if a patient presents with, an adolescent patient presents with comedones and a polymorphous eruption with scars, with a background of skin which is greasy with patulous follicular openings in characteristic distribution, the diagnosis is almost written on the patient's skin and we make a diagnosis of acne vulgaris. However, sometimes it becomes difficult to differentiate it from a condition called rosacea. And when I was doing my residency, actually rosacea was called acne rosacea because of close simulation of lesions in these two conditions. But patients of rosacea are usually middle-aged women, and they have a background of erythema, which you can actually see quite conspicuous in this particular slide. And the lesions are usually papular nodules, but comedones are conspicuously absent. The lesions occur usually on the face, and you do not get truncal lesions in rosacea. Now, the treatment of acne depends on several factors, including the severity, the gender of the patient, type of lesions, and if there is an underlying hormonal imbalance or not. So if you look at the treatment in any dermatological condition, you should speak in terms of the general measures and what is the specific treatment. So one, it's important to counsel the patient regarding local hygiene, how to clean the face. Overzealous cleaning is best avoided. They should substitute oil-based cosmetics with water-based cosmetics. Some dermatologists restrict high glycemic diets. And if there are stressors, then they should be dealt with. Now, it's important, as I mentioned earlier, to understand the pathogenesis to optimize therapy. So the first event, as I mentioned earlier, was follicular occlusion. So you have retinoic acid, benzoyl peroxide, and isotretinoin, which reverse the follicular hyperproliferation and occlusion. Then to handle the bacterial colonization, we have drugs like benzoyl peroxide and antibiotics. To reduce the sebum secretion, we have drugs like anti-androgens, because sebum secretion is triggered by androgens. And you also have a drug called isotretinoin. And if you want to inhibit the inflammatory mediators, we have drugs like isotretinoin and antibiotics. In any dermatological therapy, you can use topical therapy and systemic therapy. So the topical therapy, the indications are, it can be used in mild acne as a standalone therapy. It's always a component of therapy in the severe variants, and also very, very important for maintenance therapy. So if you want to use a word, it's always you have to use topical therapy, except when you're using a drug called isotretinoin. The drugs available for topical therapy include retinoids, benzoyl peroxide, antibiotics, and azelaic acid. Systemic therapy is indicated in patients with moderately severe to severe acne and in acne conglobata. And sometimes we need to use them in mild acne if the disease is affecting the patient's quality of life. The drugs available for systemic therapy include antibiotics, isotretinoin, anti-androgens, and the combined oral contraceptive pill. As I mentioned earlier, the grading of acne is the single most important factor which determines which therapy to be prescribed for the patient. So acne is graded as mild acne, which could be comedonal or papulopustular. moderate acne when it can be papulopustular and papulonodular, or severe acne when it could be nodular and acne conglobata. The topical agents, as I mentioned earlier, are topical retinoids, and you have a variety of formulations and varying concentrations available. The two most frequently used topical retinoids are retinoic acid and adapalene. As I mentioned earlier, they are the standalone therapy in mild acne, and they're combined with systemic agents in all grades of acne, and they are the treatment of choice for maintenance of therapy and for scars. One single side effect, which is almost universal in all patients, is dryness and irritation. So you need to titrate the concentration and the formulation with the degree of dryness and irritation the patient develops. Because there is photosensitivity with use of topical retinoids, it's best to use them at night. And the general instruction we give the patient is to apply a pea-sized amount, not only on the lesions, so it's not spot treatment, but all over the acne-prone skin, to be used at night, avoiding certain areas which are sensitive to irritation. The second drug which is used frequently in acne is benzoyl peroxide, which here again can be used as stand-alone therapy in mild to moderate acne and is combined with systemic treatments for all grades of acne. The greatest advantage or USP of benzoyl peroxide is that there is no bacterial resistance. And as a matter of fact, benzoyl peroxide prevents the development of resistance developing to antibiotics also. Here again, you start with lower concentration and build up the concentration. And you can start with shorter duration of therapy and build it overnight application. Now, antibiotics for the longest of while were used as the first agent of therapy, but with the development of resistance, their use has gone on the back burner. As I mentioned earlier, the resistance is the very important side limitation of the use of topical antibiotics as well as systemic antibiotics. However, combining them with retinoic acid and benzoyl peroxide reduces the chance of the organism developing resistance. It's important to remember that you have to combine topical antibiotics with retinoic acid or benzoyl peroxide, preferably use a fixed drug combination. Now, the fourth drug is azelaic acid, and the place of azelaic acid in the therapy of acne is in pregnancy because it is pregnancy safe, and in acne which is associated with pigmentation. You start here again with 10% and hike up over a period of time to 20%. Now, systemic agents, the most used agent are the antibiotics, which are the treatment of choice in moderately severe acne. We sometimes prescribe them in mild acne if they are affecting the patient's quality of life, and in severe acne if oral retinoids are contraindicated. The drugs available are doxycycline, minocycline, and azithromycin. Now, isotretinoin is now one of the most popular drugs available in management of acne. It is the treatment of choice for severe acne. And in moderately severe acne, which is not responding or repeatedly relapsing after antibiotic therapy. And we sometimes need to use it in mild acne if it is causing a lot of psychosocial distress. The dose is 0.5 to 1 milligram per kilogram per day, needs to be given for 6 to 9 months. And the ideal cumulative dose the patient should reach is about 120 to 150 milligrams per kilogram. Now, it's important to remember that the response to this is usually long-lasting, primarily because isotretinoin acts on all the 4 pathways of pathogenesis of acne. Some patients, however, need a second course. Now, anti-androgens and the combined oral contraceptive can only be used in female patients who have severe acne, are unresponsive to systemic antibiotics, or have an underlying hyperandrogenism. The drugs available are spironolactone, the cyproterone acetate with ethinyl estradiol, and drospirenone with ethinyl estradiol. Now, a bird's eye view of how a patient with different severity of acne can be treated. So if the patient has mild acne, the treatment of choice is topical retinoid if it is comedonal. If, however, the patient has papular pustular lesions, then you can combine a retinoid like adapalene with benzoyl peroxide. Very important to remember that all patients of acne, when they become all right, would require maintenance for the longest of times. Usually the maintenance therapy is topical retinoids unless the patient is pregnant, when we switch over to azelaic acid. If the patient has moderate acne, then the treatment of choice is oral antibiotics with topical retinoids or benzoyl peroxide. It's important to remember not to combine oral antibiotics with topical antibiotics, because the chance of developing resistance is very high if you combine the two. If the patient has nodular acne, then oral isotretinoin is the treatment of choice. In females, oral retinoids need to be used under extreme supervision, and oral antiandrogens plus topical retinoids can be used, as I mentioned earlier. Here again, if the patient is not planning a family. In nodular and an acne conglobata, the treatment of choice is oral isotretinoin. In acne conglobata, sometimes you may need to combine oral steroids, because sometimes oral isotretinoin causes a severe flare-up, and that may lead to scarring. In females, here again, the same caveat applies, that oral retinoids need to be used under extreme supervision, and oral antiandrogens and topical retinoids can be used if the patient is not planning a pregnancy. Now, coming to disorders of the hair, some definitions before we delve into the disorders. So alopecia is loss of hair. Hirsutism is excess terminal hair in females in male distribution. In contrast, hypertrichosis is excess terminal hair in any part of the body with no special pattern. Alopecia can be scarring alopecia when it is called cicatricial alopecia, or non-scarring alopecia when it is called non-cicatricial alopecia. In scarring alopecia, the hair follicle is destroyed, so it is irreversible. In non-cicatricial alopecia, hair follicles are not destroyed, so the condition is generally reversible. In cicatricial alopecia, the skin appears shiny with the follicular openings being absent. In contrast, in non-cicatricial alopecia, the follicular openings are visible. Signs of inflammation are present in cicatricial alopecia and absent in non-cicatricial alopecia. A prototype of cicatricial alopecia is pseudopelade. In contrast, for non-cicatricial alopecia, prototype is alopecia areata. And this is the alopecia which we are going to discuss. It's an immunological problem. It could be skin-specific autoimmune disorder, or it could be associated with other immune-mediated diseases like atopy, vitiligo, autoimmune thyroiditis, and pernicious anemia. There is some role of genetic factors and emotional factors. Clinically, it is characterized by presence of discoid patches of non-cicatricial alopecia. That means this alopecia can recur. A characteristic feature, I know this is an MCQ which comes very frequently in your NEET exam, is the presence of exclamation mark hair at the periphery of the lesion. The hair is usually broken about 4 millimeters from the scalp due to this particular constriction, which you can see in this diagrammatic representation. Scalp is the most frequent site, followed by mustache, and you can see a lower picture of the beard area. Eyebrows and eyelashes are sometimes affected. Now, there are certain variants which have a bad prognosis. One is ophiasis, where there is a peripheral loss of hair around the scalp. Now, this is the suboccipital area of hair loss. The patient can have complete loss of scalp hair when it is called alopecia totalis, or the scalp and the body hair could be lost, as happens in alopecia universalis. These are variants of alopecia areata which have bad prognosis. Associations can be nail pitting, which is again seen in about 10% of the patient, and usually more frequently seen in patients with extensive alopecia like alopecia universalis. Other autoimmune diseases I mentioned earlier and atopy may be associated with alopecia areata. Now, if the patient has single or few lesions which are of short duration, that's less than 6 months, it may be worth its while to observe, because spontaneous recovery is frequent. However, if the patient's lesions have persisted for more than 6 months or there is progress, then one can start topical steroids, topical minoxidil, and topical PUVA and PUVASOL. Now, PUVA is photochemotherapy, where you give psoralen and expose the patient to UVA, either from chambers or from the sunlight. If, however, the lesions are extensive or the patient has alopecia totalis and universalis, you need to institute oral immunosuppressive therapy in the form of steroids or azathioprine, and the new kid on the block is tofacitinib. Now, other causes of alopecia include non-cicatricial alopecia include androgenetic alopecia, which could be a male pattern alopecia, or you can have a similar alopecia, which is androgenetic in females, which is known as female pattern hair loss. You could have the patient coming with these bunches of hair, which are shed daily, something which happened very frequently after patients were infected with COVID. This condition is called telogen effluvium. It usually occurs after a mental stress or an illness, or the patient could have something like this, which is known as traction alopecia due to traction of the hairstyle. The patient can have cicatricial alopecia. The prototype is what is, the image shows what is known as discoid lupus erythematosus, or another condition which causes cicatricial alopecia is lichen planopilaris. Cicatricial alopecia also develops after traumatic injury due to physical or chemical causes, or it could be idiopathic. Now, this is a condition called pseudopilardo-Brock, very fancy long name, but you can forget the name after the lecture. Now, coming to the disorders of sweat. Now, this is a condition called malaria. We dermatologists love to give fancy names to common condition. The other name of this condition is prickly heat, which is due to hot, humid climate, resulting in obstruction of the eccrine duct, resulting in spillage of the sweat into the dermis. It clinically manifests as small erythematous papules, with very subtle papules which are surmounted by vesicles. The treatment is just avoiding hot, humid environment and using soothing agents like calamine lotion for symptomatic relief. Now, this is of the eccrine, obstruction of the eccrine sweat gland. The counterpart of this in the apocrine gland results in a condition called hidradenitis suppurativa, which I mentioned earlier when I was talking about acne conglobata, because this is a manifestation of follicular occlusion syndrome. It is characterized by nodules, pustules, cysts, and bridging sinuses, and comedones, mainly polyporous. Now, this is something like a deja vu for acne conglobata, similar, but it's usually seen in areas of apocrine glands like axillae, groins, and the perianal region. Now, usually seen in obese individuals, so very important to lose weight. We treat them with intralesional steroids. You can actually see these marks where the patients had intralesional steroids. So the active lesions have subsided to leave behind scars. We have to give these patients antibiotics. Sometimes need to use the drug isotretinoin, which again has been used in acne, which is also an occlusion, which also has an occlusion pathology of the pilosebaceous orifice, and a drug which is now FDA cleared, adalimumab, which is a biological, but the response is varies from 50 to 60%. I think that's all from my side. And thank you once again to Team Elsevier. I would be happy to take any questions.
Ma'am, we have one question in the Q&A section.
Why would we combine antibiotics with retinoic acid and benzoyl? Now, you need to combine retinoic acid and benzoyl peroxide with antibiotics for the simple reason that with antibiotics, there is a great chance of resistance of the organism. And benzyl peroxide has been scientifically proved to reduce the resistance. And we don't want to combine a systemic antibiotic with a topical antibiotic for the same reason that you don't want to increase the resistance. The second question comes from Prasoon Sharma. What is the long-term prognosis of alopecia, ma'am? Now, depends on which alopecia are we talking about. Are we talking about alopecia areata? Then I've already enumerated the bad prognostic features. So if your patient has ophiasis, alopecia totalis, alopecia universalis, has nail changes, then the prognosis is not as good as if the patient has single patch. If it is for, you're talking about androgenetic alopecia, there again, you need to, because it's a genetic problem, you would have to use long-term therapy with minoxidil. If it is scarring alopecia, then the treatment for scarring alopecia would be either removing the scar if it is a small scar, or hair transplantation. Does that answer your question? Okay, then how does psychology affect dermatology condition? I think I mentioned that in acne. I also mentioned that in alopecia areata. Yes, psychology, now we have a specialization called psychodermatology, which there is a 1 year or 2 year fellowship internationally. And a lot of my residents are doing that fellowship. So in every disorder, why only in dermatology? If you look at cardiac, you look at blood sugar levels, you look at your sleep, everything is affected by things like stress. And that is why yoga is becoming so important in our lives, because it has been found to influence a lot of, or improve a lot of disorders, not only dermatological disorders, but also non-dermatological disorders.
So that's all, ma'am, for the Q&As. We have, like we promised in the beginning of the session, we also have quizzes for our participants. So I will just go ahead and start flashing it on screen. So I'll give this question a few more seconds so that everyone can answer. So yeah, we are moving ahead to the next question. Before we do that, let me show you the correct answer. So the correct answer is the fourth option.
You want me to tell the answer?
Ma'am, you can do that. You can also, tell them why is it like the fourth option?
Why is the answer? Okay. So the correct answer is now, we do not have, as of now, preparations available for of spironolactone and cyproterone available commercially. And we have adapalene available. This patient has mild acne. So adapalene is the treatment of choice. As I mentioned earlier, monotherapy with topical antibiotics is a complete no-no. So the correct answer is adapalene.
So I'm moving on to the next question. Please note that the answers are anonymous, so please feel free to participate as per your understanding. I'm giving a few more seconds to this question, then we will move forward. So the correct answer is the first option, doxycycline into 4 weeks plus topical benzoyl peroxide. Ma'am, I'm handing it over to you to explain.
Yeah. So now this is the correct answer because I did mention that benzoyl peroxide reduces the chance of the bacteria developing resistance. So we are giving an antibiotic. So it's good to combine a systemic antibiotic with a topical benzoyl peroxide. Now, the second is doxycycline 8 weeks with topical clindamycin. This is a complete no-no because you'll be using 2 antibiotics. Moreover, this girl is getting married in 2 months, so you don't want to get her on doxycycline at that particular time in case she gets pregnant. Third is isotretinoin is again a complete no-no because she's likely to get married and you need to use contraception after isotretinoin. I mentioned that in women with childbearing potential, you should be careful. And again, isotretinoin should not be combined with topical retinoic acid. I think in one of the slides I did mention that the topical retinoic acid should not be combined with certain drugs like isotretinoin. Topical steroids are never used in acne. So the fourth choice is again wrong. So the right answer is doxycycline with topical benzoyl peroxide.
So let's move on to another question. And this will be the last question. I'll give a few more seconds. Okay. So the correct answer to this question is, ma'am, would you like to tell everyone?
Yeah. So erythromycin, now this is nodulocystic acne or acne conglobata. So I mentioned in the slide that isotretinoin is the drug of choice or treatment of choice. So this is what we have to give. Now, erythromycin and tetracycline can only be used if the patient is not willing to take isotretinoin. So there are certain people who are not willing to take isotretinoin. In that case, you can give. Or if it's a female patient and not willing to take, a married female and doesn't want to take contraceptive measures, then you can give tetracycline or erythromycin. If the patient is planning a family, then again tetracycline becomes a no-no. So then erythromycin is the drug, but the response is not good enough. Now, steroids would initially improve the patient, but they are just not the drug to be given in acne. As a matter of fact, steroids themselves cause acne. So the treatment here, the answer would be isotretinoin.
Perfect. Ma'am, we have a few more questions on YouTube. I will just read out to you. So the first question is, can we completely switch from topical applications of drugs to diet-based treatment?
It again, as I said, that there is no direct link as such. So only some dermatologists believe that diet plays a role in acne. As a matter of fact, when I was doing my post-graduation, my thesis was on diet and acne, and I did not find any correlation. So if the patient has very severe acne, then I would strongly recommend that they take therapy rather than just go by the diet restrictions, because acne, though considered self-limiting condition, tends to cause a lot of scarring, an immense amount of scarring, and that scarring is more difficult to reverse than the acne, and it's more expensive to reverse the scarring. And if diet at all, if you restrict the diet, it's going to take the longest of while for the patient to improve. So I would strongly recommend that they take appropriate therapy depending on the grade of their acne.
Okay. So, ma'am, we have one more question. What are some effective treatment options you would recommend for kids who have severe dermatitis and have not responded well to steroidal creams?
What creams?
Steroidal.
Steroid-based treatment.
Steroid.
Now,
Okay.
this is actually becoming a dermatology clinic rather than, talking about the lecture which I've taken, but nonetheless, I will answer that question. So if there is dermatitis and the patient has a background of an atopic, a condition called atopy, then the most pivotal therapy is actually using moisturizer and using appropriate cleansers so that they do not degrease the skin. So that is very important. Then you have lots of other options depending on the severity. But as I mentioned, the pivotal therapy is moisturizing the skin and moisturizing the skin and moisturizing the skin.
Another question. What is the risk of developing cutaneous and systematic malignancies in an organ transplant?
That is beyond the purview of this lecture, no?
Okay, maybe we can answer them later on.
Yeah. So there is one come in the Q&A. Ma'am, does protein supplementation by bodybuilders? Yes, that's a very important question, I think. Yes, some of the supplements which are used by the bodybuilders and prescribed by the trainers in the gyms actually contain anabolic steroids, which are muscle building steroids, and they do cause an acneiform eruption. And I have seen lots of people who take these supplements and whey proteins as well. So it's not only the anabolic steroids, but the whey proteins themselves, they can trigger acne. So now you have what is known as bodybuilders acne. This is the entity which has been recognized, and we ask these patients not only to stop these supplements, and then we have to give topical retinoids to these patients as well.
We have one more question in the Q&A.
Yeah.
What are the most high yield topics in dermatology?
Topics in dermatology for NEET PG, ma'am. Okay. High yield. So in the book, there is a synopsis for the important topics. And there is also, I have marked the must know and should know topics. So the must know topics are the most high yield topics in dermatology for NEET PG. Does that answer your question? Well, he can't respond, but
Yeah.
You can at least say yes. Type a yes.
So he says, definitely, ma'am. Thank you.
Okay.
Okay. So with this, we have come to an end to our session. Thank you all for joining us today for this informative webinar on diseases of skin appendages. It was a pleasure to have Dr. Neena Khanna share her expertise on acne and hair disorders, which are prevalent among the young generations. I hope you found this session insightful and informative. We are grateful to Dr. Neena Khanna for taking the time to enlighten us on this topic. And we are also privileged to have her as a speaker today. Once again, thank you all for being a part of this webinar. Have a great day ahead.
Thank you.